everybody really cares. Everybody wants good outcomes. You have staff who work hard, who are talented, and who really want patients to get better. And then you've also got patients who really want to get better and are doing their best.
Yeah.
But something about the system, the way it works, the way it's structured, you just don't get good outcomes.
Yeah.
You don't help people to live the life they want nearly as much as you'd like.
Yeah. We've worked together quite a long time, haven't we, in anthropology and mental health kind of research, but we got into it in very different ways. I think 25 years ago, I was a kind of civilian trying to do anthropology of India, started a PhD, and I sort of went nuts, really. I had, I suppose you could say, a breakdown. I like the language of going nuts. I think that captures more of the kind of comedic and performative nature of it, but maybe, we could say more about that another time. But I kind of went nuts, got diagnosed with bipolar disorder and dosed with lots of drugs, admitted to hospital. The more treatment I had, the worse things got, not necessarily because of the treatments, but just there was more and more of everything. And I sort of reached a point where I was living on benefits for about 10 years. All my kind of academic colleagues were kind of going ahead and leading exciting lives. So I was told not to expect to get well, not to expect to work again, not to expect really all that much from life. And really, I just had a kind of epiphany, an unlooked for, seemingly random stroke of luck, really. I felt I can change this. So I discontinued all my treatments. I stopped taking all my medicines, huge numbers of meds by this stage. Changed aspects of my life, came off benefits, and stopped being sort of, in a way, I'd learned how to be bipolar, and now I learned how not to be bipolar. Not an easy thing to do, a lot of emotional labor, but I did think something that carried me forward, something that made me think this is worth it, this is really good, is if I go back to my anthropology PhD, I think but I'd make it about mental health, not about India and stuff like that I was working on before. I think I might be able to make a difference. I think I might be able to improve mental health care because I can see that anthropology is able to kind of attend to the details of people's lives. It's able to kind of revision things that are going on in a new and productive way.
Absolutely. My route into mental health is pretty opposite. So initially I was going to be a mathematician. I had the aims. But then during my teenage years, I'd had friends with mental health problems. And during that first year of maths, I just had a lot of friends who were really suffering. And at that point, I decided, actually, I want to do something about this. I had the feeling that, there's going to be a route to do this. I'm going to learn techniques. I'm going to learn strategies. I'm going to learn various things that will help me make people's lives better. So at that point, I swapped into a psychology degree. I learned the psychology, I learned about mental health, I learned the science. And fundamentally, I kind of realised it wasn't good enough. So a lot of what we were being taught just seemed so separate from the reality of people's experience. I decided, actually, I've just got to work in frontline mental health and see what it's like. So I did. I worked in a variety of jobs. I've worked in psych wards, in the community, and...
What was it like?
Well, everybody really cares. Everybody wants good outcomes. You have staff who work hard, who are talented, and who really want patients to get better. And then you've also got patients who really want to get better and are doing their best.
Yeah.
But something about the system, the way it works, the way it's structured, you just don't get good outcomes.
Yeah.
You don't help people to live the life they want nearly as much as you'd like. So really, I've become quite disillusioned with the whole situation.
Yeah.
And then I met you and ended up seeing anthropology and some of the benefits it brings.
Yeah. When I started to do my PhD research, I went to meet with lots of psychiatrists, and I was quite worried about saying, I'm doing anthropology. I thought they would think, what the hell is that? This is a waste of time. And what I discovered is quite a lot of psychiatrists don't bother with the mainstream research, randomized controlled trials of drugs, of interventions of various kinds. And I think they will say, I kind of don't believe it. It doesn't really help me do my job. This isn't, this blurs the line really between advertising and genuine academic research. You know, there's a slight sense in which we're just testing products that are competing products in a marketplace. It's not really that it's all bad. It's not that there shouldn't be any meds or anything like that. But there's something missing in research that randomized controlled trial after randomized controlled trial just seems like it's not advancing. We don't have new treatments. Healthcare isn't better than it used to be. So there's something wrong with research, as well as there's something wrong with the way that mental health care is organised, notwithstanding the high calibre of staff and notwithstanding patient desires to get well, I think, really.
It's easy to look at the situation and to go, actually, if we had more money, it would be better. Because services are really struggling. Staff are overwhelmed, caseloads are high, and services are really feeling that stress. But I don't think funding's enough. I think that actually the way we're working isn't necessarily getting patients the outcome we want.
Yeah. One of the things I've tried to do in my work is use anthropological understandings of institutions and communities to try to make sense of why it is that this way of organising doesn't work or doesn't work as well as we'd wish. And one of the things that I do is I think about mental health care as an accountable bureaucracy, because we find accountable bureaucracies in lots of different places. We may have a workplace that places certain demands on us that's a little bit like a cage. Max Weber famously said the iron cage, that might constrain you in what you might want to do. But when I watch mental health professionals, I see something a little bit more subtle, really. I see that the institutional setting, the way that it imposes responsibilities on members of staff, the way that it places certain sorts of informational demands on members of staff. So everything has to be written up in a certain kind of way. Decisions have to be defensible, evidenced in a certain kind of way. It changes how people see distress. It changes how people feel about what care should be like. And there's an example in the book. So in the book, I co-produce a chapter with someone who's a member of staff, and that person is also a patient as well. And that person says, well, when I'm a patient and I'm on a ward, I know that medical notes about me are highly unreliable. But when I go to work on a ward, I believe notes. I don't think of them as being unreliable. And that's because you just can't do your job and be skeptical about medical notes. You won't be a good colleague if you're doubting your kind of colleagues all the time. So your sense of what's true or what's likely or what's probable is changed by the institutional setting. And that feels like quite an important way of looking at it, really. Likewise, seeing people as embodying risk, for example, of needing safeguarding, that arises out of certain sorts of institutional demands. And I think it gets in the way of really listening. It gets in the way of really caring for people. It's as if whenever a patient sees a member of staff, it's like there's a third party in the room. And the member of staff is really talking to the third party in the room to show they're doing everything properly. But that third party in the room is concealed from the patient. So the patient never really figures it out. In a sense that, whether it's a nurse or an OT or, whoever it is, they're never just talking to the patient. And that, I feel it sort of captures something about why, patients who feel angry at care aren't necessarily wrong. Sometimes they're just right. Sometimes they're just sensing that clinicians aren't listening, aren't attending to them. And I think this way of understanding the bureaucratic context might be a way both of explaining why and about thinking about how we might do things better in the future.
I think you're completely right that when you're supporting somebody, you always want to help them as much as possible. And clinicians do want to do the listening. Yeah. And you find ways to have elements of it. Yeah. But other things also get drawn into the picture. So, as you say in WISC, you always have to be aware that you have to follow the right procedures. You have to think about what's going to happen if actually something really terrible happens. Yeah. And if that tragedy occurs, what's going to happen in the coroner's court. Yeah. But it's also a bit counterintuitive and doesn't give you the flexibility to necessarily give the help needed. So, for example, with WISC, if somebody expresses that actually they are feeling suicidal and might act on that, then you've got to take it seriously. And that's the right thing to do. It's a really serious disclosure and you've got to help the person. Yeah. But then you have that layer of wanting to help. But then you've also got to do things like suggesting, well, if you don't feel like you can keep yourself safe, phone 111 or go to A&E. And in some cases, that's the right thing.
Yeah.
But often that kind of process can be really abrasive.
It's a nightmare. That's the last thing I probably shouldn't say this, but it's the last thing you want to do, really. Yeah. I mean, it's the right thing for you to say, but from a patient's point of view, you don't want to do those things. Yeah.
Absolutely.
Yeah.
Especially when you hear a patient and they're talking about how actually they do this quite a lot and it's not helping them.
Yeah.
They're finding the A&E unhelpful, abrasive. 111 perhaps is upsetting them or triggering them, but you still have to recommend it. Well, actually, when managing that risk, it kind of is bullshitting the patient.
Totally.
I'm telling them you ought to do this, while also kind of knowing I'm saying that because I have to do it and I have to be accountable. I think when you're treating clients, it's really easy to have the theory you understand to affect the interactions, the formulation, the way you conceptualize a client's distress. And then habitus, which is the idea of kind of your way of being in the world, your thoughts, your assumptions.
You feel for the game.
If you have a broader concept like habitus, it gives you a different way of understanding the client.
I find anthropology's use of theory is so much, it has so much to offer really mental health research, because it's not really that we're engaged in a kind of representational arms race. Like, we have the best way of representing madness, we have the best way of representing depression. It's not really that. But we have got alternative conceptual resources that might produce different sorts of knowledge or tell a different kind of story, potentially for different purposes. So I do find that there's something very limiting about thinking there's only one way to narrate my depression, there's only one way to narrate my madness. I don't think that's likely. And sometimes, it can feel quite depressing, I think, when people feel that the only authoritative account is the one that the doctor gives. It's not necessarily that account's wrong or false, but it's a version that the doctor will use so they can justify themselves, defend themselves, give treatments of a certain sort, which may be helpful, which may not be helpful too. But yeah, habitus, I think I use habitus also when thinking about my own life. I write about myself and I juxtapose my autoethnography with medical notes. And again, it's not to say like who's right or who's smartest or whatever, but it does say things that could be read as mood events, low mood, high mood, can also be read really as being connected to things that I really believe in, ethical commitments, a kind of learnt way of negotiating the world. So you know how when I narrated how I got into kind of working in mental health research, I said like I kind of learned to be bipolar and then I learned not to be bipolar. And the concept for habitus kind of helps with this as well, really. So that I think there's a sense in which I wanted to be true to certain sorts of values, not necessarily great values, not necessarily things that I have a lot of time for now, but my fidelity to those values made life very hard to live. And the way that what that looked like from the outside was, I was kind of had unstable mood. And I think maybe I did, but I had lots of other things as well. And that might have to do with, yes, values and commitments, tastes, preferences, styles of friendship. And if you just abstract, say, things about mood and say, well, this is the problem. And we have we can pinpoint that with some meds or with standardized talking therapy. It can feel quite, first of all, it can feel quite naive. And it can feel, if you meet a psychiatrist and you tell them about your broader life and they reply talking only about your mood, you're not being heard, not being listened to.
But it also strikes me that anthropology's ability to reconceptualize distress goes beyond just people in the mental health system.
Yeah.
So if you think about the popular narratives around mental health, they're all very medically focused. They all feature around the same thing. Yeah. I realised I had a problem. I went and got help. I received these treatments. I learned these coping mechanisms. And then things got better. Yeah. And the way that often ends up being expressed doesn't allow for the widths and narratives of distress. It's not isolation, it's not lack of community, it's not so many broader things. And it really cuts off that width and varied humanity of people with mental distress. And it strikes me that by anthropology broadening our understanding and definitions, it has a lot of potential.
And a lot of what happens in mental health care, as we're saying, it's not really determined by science, it's determined by the institution. the way I express this, and I bore people with it, but I always say, like, mental health care is like a gas that will expand to fill any institutional space into which it's placed. So at the moment, with the current informational demands and the current kind of issues about accountability, responsibility, safeguarding, mental health care looks this way. Change the institution, the discipline will change. The whole of mental health care will change. It seems to me this is an opportunity. This isn't impossible. We can imagine changes. And my sense is very much there's a lot of discontent from the inside. I meet lots of clinicians of all sorts of roles, levels of experience, who say things aren't working. We need different approaches. We need to acknowledge the shortcomings of existing ways of research that don't really acknowledge the problems. So it feels kind of an exciting time. And it feels like anthropology should be in the mix. But the assumption is that just having lived experience is itself a form of expertise. And I'm not sure. Like, I don't think my lived experience is expertise in itself. My expertise is as an anthropologist. And I think because anthropological training helps me take experience and turn it into data, basically. It stops things just being anecdotes or opinions or something that could never be representative, and turns it into something that could be investigated and critiqued or contribute in a certain kind of way.
I think you're absolutely right that there are a lot of efforts to bring lived experience into research, but often they can feel a bit tokenistic and a bit half-hearted. I think lived experience can be a shortcut. It can give you insights. It can help you work out what questions to ask.
Yeah.
But it's not expertise in itself.
One of the changes that I think I might be looking for are attempts at institutional reform that create more space for human dialogue. And that might require spaces where the burden of accountability is reduced. So where at the moment clinicians just can't do, in a way that they have to bullshit, they have to kind of conceal their purpose, they have to be insincere, even where a patient's revealing the most painful, experiences by making themselves very vulnerable. The clinician in a way has to continue to be a bullshitter. And, it's not a nice feeling for anyone really. It's probably why there's high burnout amongst staff. But I think we could envisage a system where some of those exchanges, some of those moments of care might be dislocated from moments of responsibility. So it's not really that, sometimes people get into tricky states, sometimes people need to be on a ward. But maybe the decision-making around that might be separated from some of the moments of care that could take place in other settings. If we make it a little bit richer, a little bit deeper, how will that work for you? Can we reach a mid-position? Can we improve things? Can we have iterative change rather than fury on the edges that leads to no change at all?
I think the future of mental health needs to recognise that there are lots of different types of knowledge, and that actually there's lots of different types of expertise and lots of different voices. And if we're going to make the progress we need to make, we really need to draw on all those different disciplines and the expertise of the people who work in the setting, the people who use the setting. And really we need to find a way to integrate all of these types of knowledge and hopefully find a better way forward.